And that is how it's going to look like. So here you can see a different structure. So you have your two vessels, and you have a couple of fascias that are important. So you have the fascia lata that is on top, and then you have the fascia iliaca underneath. The fascia iliaca is going to actually separate the vessels and the nerve. So it's very important to pass both of these fascia. And that's what they were using when they were not using the ultrasound machine, as a kind of pop. So it's like the two pop technique. So you feel a little pop when you pass the first fascia lata, and then another one when you pass the fascia iliaca. And that's very important to feel these two pops. Then you're close to the nerve, and then you can inject. Another picture of these structures, the fascia lata on top and then the fascia iliaca underneath. And here is how it would look like. That the fluid expands around the nerve, and you can see the hypoechoic fluid just surrounding the nerve, and that's exactly what you want. Ideally, and here we have only the fluid coming on top of the nerve, but ideally what you want to do is first access the nerve kind of below it and inject below the nerve, so that you work on that side of the nerve, and then you move on top of the nerve and you give some more fluid, some more anesthetic on top of the nerve. Doing that, you really surround the nerve by anesthetic, and your block will work better. And usually, even for adults, 10 milliliters are enough if you do the procedure properly and you are really sure that you are surrounding the nerve and not injecting in the soft tissues. When you do inject in the soft tissues, then for sure you're going to need more, and that's when they go up to 20 milliliters in adults. Pitfalls. So if your patient has a huge quadriceps spasm, back off. It means that you have hit the nerve, and that's why the patient is having spasm. So just get out with your needle a little bit, and then you'll be safe. If there is no dissection around the nerve when you inject the fluid, it means that you have not passed the fascia iliaca. You're just injecting into the soft tissue, so your block might not work as well. It might still work, though, but not just as well. And keep in mind that the pain relief is going to come usually within 8 to 10 minutes, so it's not immediate. You have to come back and reassess the patient to make sure that it has been working. The full blockade is going to be there within 20 to 30 minutes, and the total duration depends on which anesthetic you use. If you use the lidocaine, usually it's around 3 hours. So definitely a block that is not so difficult to do, that is very, very useful and just provides to the patient a good pain control. After that, you can action if needed or do any other procedure with your patient not being in pain. Let's move to another case. So here is a 14-year-old male who presents with extensive left hand laceration after having slipped on ice, and he actually fell on a glass that was in front of a pub downtown. Doesn't have any fever, he's a bit tachycardic because of the pain, and that gives him a bit of hypertension as well. Otherwise, fine. When you look at his left hand, the palm has several lacerations. Some are deeper than others, and there is no active bleeding anymore, and he's neurovascularly intact, so he can definitely move his fingers well. He has a normal sensation. So looking at that hand, you're like, okay, but there is a lot of work to be done here. How can I get a good anesthesia of his hand without putting him to sleep? To block or not to block? We just go back to the same question. Block. So that is the second nerve blocks that people do the most. To access 3 different nerves: the ulnar nerve, the median nerve, and the radial nerve. You usually access them in the mid-forearm area, because doing so, you keep the sensation fibers off, but you keep the motor fibers, because the dissect from the nerve a bit higher, more in the arm. So it's actually great for, first of all, your assessment, because you want to make sure that your patient is able to move when you do any procedure. And also for the patient, because it's actually better. Like it's you freak out a lot when you cannot move your hands, so it's just better for them. Here is some picture about the areas of interest. So these three nerves have different coverage of the hand. Ulnar nerve is mainly the fifth and part of the fourth finger. Then you have for the palm the median nerve, and for the back of the hand the radial nerve for the other fingers. That is theoretically. In real life, you have a lot of like overlap and differences in patients. So that's why the recommendations are to do the three nerves and not only one, or sometimes eventually you could do two, depending on where it is, but try never to do only one, because you might end up with anesthesia that doesn't help you. There is some literature about that actually comes from here with our dear Jason Fisher. Actually article explaining how to perform nerve blocks in kids, and explaining that it's actually working very well. So that's how you would put the patient, the probe, and yourself. So meaning that it's not shown on that picture, but you can assume that the machine is facing, so on the other side of the bed. You have your probe in a transverse position, and you look at your anatomy here. So for the ulnar nerve, you're going to look over your ulnar bone that you can see here, which should be medial if you look at the patient globally. And then on kind of top / a bit laterally to the ulnar bone, you're going to find your nerve and then your artery. So you can always look for the ulnar artery first. You can palpate the ulnar artery at the wrist, and then follow with your probe your ulnar artery up to the mid-forearm, and the ulnar nerve should be kind of next to it. And here's how you would approach it. It's the same. You just keep your needle in your plane. You try to really get your needle on your ultrasound screen all the time. You just move slowly, until you are able to move the nerve with your probe. And when it is the case, you inject a little bit, look where the fluid is coming, and then if it's around the nerve, perfect, keep injecting. If it's not right around the nerve, move a little bit more. And here you can see the fluid just surrounding the nerve. For the radial nerve, you can definitely use the same technique, meaning that you start at the wrist, because you can palpate radial artery, and the radial nerve should be close to it. The radial nerve usually sits laterally to the radial artery, and the radial bone is even more lateral. And then you move up to the mid-forearm, following your nerve. Sometimes it can be a bit tricky, because the radial nerve cannot sit with the radial artery, a bit more cephalic. But if you follow your nerve from the wrist, usually you are able to catch it. And for the median nerve, that one is a bit more difficult to find, because there is no to it that you can really look for. So it's usually really sitting in the middle of your forearm, in the middle of muscles. So that's where your fanning technique is very important. You just put a probe in the middle of your forearm and you fan to look for that kind of hyperechoic structure that jumps out of the spine, which would be your median nerve. Here's an example of nerve block. So here you have the fluid, the anesthetic surrounding your nerve that is just left the hypoechoic structure, right? And then it's on top of muscles. So that study was a good success study. So they got 10 patients, 9 to 17-year-old. The patients were very happy with that local anesthesia. They got significant pain reduction, no complication. The parents were really very happy as well and were willing to get the same procedure done on them, should they need that, because their kids were, the pain relief for the kids was so good. And Jane was also very happy, actually, because he was pretty quick doing these procedures. It took him around 60 to 70 seconds per nerve block, so meaning less than 4 minutes per patient to catch the 3 nerves. So it's definitely something that is quick and easy. It definitely needs some training, though. So that's the thing that we all have to keep in mind. Just get trained. And for that, what you can do is use some website that exists. So Sono Guide is the one that everyone would always refer to. The problem is that right now they're a bit down. There is still a couple of things that you can access. EM Procedures is another one where they have nice videos about YouTube videos about how to use the different type of blocks. USRA is something that is a bit more done for anesthesiologists, but as Nizora, actually, but very good information about the anatomy, especially. And then podcasts, so 5 Minutes Sono, Ultrasound podcast, or RP2SK is also, these are also things that you can look for. So take-home points. The pearls are that ultrasound-guided regional anesthesia is a standard practice right now. It's quicker, it's safer. It then requires less anesthetic and less supplementation of opioids or any other type of pain management. The anesthesia is going to last longer and there's less complications. Rules are that you definitely need to learn how to use it. So you need to know very well your anatomy. You need to know the contraindications. You need to know the max dose of the anesthetic that you can use, and you need to train yourself to do it. So train yourself is not a big deal. You can use phantoms, look at nerves when you do your soft tissue scans, just to make sure that you're able to recognize how nerves look like. And the more you do it, the more comfortable you're going to feel. And it's actually better for you and your patients. That's it. Don't forget to sign in and do the evaluations to get credits. And you can always reach me at these different things, either email or Twitter, and look at our P2SK website.